You
Recording in progress.
Good evening, everybody. I am Dr. Somin Shah, gastroenterologist from Gujarat Hospital, and we are now this in the hepatology webinar series. This is hepatology lecture 2, and our eminent faculty is Dr. Mithun Sharma. He is heading the Department of Hepatology at Asian Institute of Gastroenterology, Hyderabad, world-renowned institute of the gastroenterology. Along with us, I have my PG teacher, Dr. Bhagirath Solanki, who is head at the Civil Hospital Ahmedabad, a very academic physician, Dr. Bhavin Modi. Dr. Nilesh Ludhani is joining us soon. And Dr. Mithun Sharma needs no introduction. He is in AIG since many years, and he is doing phenomenal works in the hepatology with many publication of the research paper in very reputed journal. So over to you, Mithun sir. Without wasting the time, we will just start this series. But this series is basically designed for the physician rather than gastroenterologist, and the few resident doctors will be there. So you just keep this audience in the mind. So in day-to-day practice, it will be useful for them.
Sure. Thank you, Somin, for the introduction. So I have kept that in mind to target the audience. So basically today, in the next around 40 minutes or so, we will be discussing on alcoholic liver disease. But I have put the term here, no longer alcoholic liver disease. This is because there has been some change in the terminology of how we define alcohol-related liver disease. So first of all, we should understand, we loosely keep writing in the prescription, patient is alcoholic or patient has an alcohol use disorder. So what does alcohol use disorder actually mean? Let me tell, these are all Western definitions. So alcohol use disorder means if a male person takes more than 3 drinks per day or a female takes more than 2 drinks per day, each drink comprising of 10 grams of alcohol. I will tell you how to calculate the grams of alcohol. Or if the person has episodes of binge drinking. I will also come to what does this binge drinking means. Now, when someone goes to purchase a bottle of alcohol, we find this written as 88 proof. In all the bottles, this is still mentioned along with the alcohol by volume. Now, what does this 88 proof means? So the 88 proof means, so proof was basically a government documentation of distilled beverages, alcohol content. Now, what does 1 proof means? If you are taking drinks made in United Kingdom, 1 proof is equal to 1.75 alcohol by volume, while in US it is 2 times of alcohol by volume. So if we have a 88 proof, and if it's a US product, you divide it by 2, it means it has 44% of alcohol by volume. The legally allowed alcohol in India is 42.6%. So in day-to-day practice, we need to know the percentage of alcohol in a bottle of liquor that we purchase. Now, why does this concept of proof came? So in the olden times, there was something called the spirit tax. So what was a spirit tax? So in UK, they used to find out whether the alcohol contained in this bottle is actually pure or not. How did they find it out? They used to soak these gun pellets in the bottle of alcohol and then lit it up with fire. If the pellets burn rapidly, then it means that the alcohol content in that bottle is at least 57%, and they considered it as a pure form of liquor. However, This concept of finding whether the liquor is pure or not has been long replaced since the 1950s by the concept of alcohol by volume. So what is the problem of alcohol intake worldwide? On this graph, you see the percentage in prevalence of alcohol use disorder in adults 15 years or older. This is already a 5-year-old data. But if we see that India falls in a zone which is around 4.1 to 6% as per the prevalence. On the other hand, if we see what is the age standardized disease burden of alcohol use disorder per 1 lakh population, we see again India falls that it affects possibly around 229 to around 260 patients. So we know that coming from a state and working in a South Indian state, we know that it is believed that these 5 South Indian states consume half of India's liquor. And when there was a lockdown that was declared, these 5 states lost a significant percentage in the revenue. So the states earn quite a lot from alcohol. So this is in crores, the amount of rupees that goes to the state from sale of liquor. So we understand that the government also has a role in why people drink. This was how people tried to settle down during the lockdown. So the moment lockdown was appeared, people tried to rush to the shops to keep these bottles. And then when the lockdown opened, there were large queues in front of the liquor shops. So in addition to this legalized liquor, there is something called illegal liquor in India, which I will come. And if you see, this is in liters, lakh liters, the amount of illegal liquor that is seized in the different states, with highest in Karnataka. So coming to the type of drink, I think this most of the people know. So we have different type of alcoholic beverages, starting from beer, wine, fortified wine, rum, whiskey or vodka. This is called actually distilled spirit or hard drinks. People in the southern part will know about arak and toddy. Then any of the rum, whiskey and vodka, if it is made in India, it is called Indian made foreign liquor. In south of Goa, everybody is aware of the drink called Feni. I'll just show what are the sources and what is the approximate alcohol content, though it varies from brand to brand. Beer is mostly made from cereals. Its content varies between 3 to 10%. Wine is mostly made from grapes, apricot, and plums, and has around 8 to 14% alcohol. There will be some wine which are called fortified wine, which will have 14 to 20% of alcohol. Coming to the distilled spirits, that is rum, whiskey, and vodka, it contains around 40% alcohol. It is made from fruits, cereals, and sugarcane. Arak is found in southern India, made from coconut flour and sugarcane. It also has around 33%. The Indian-made foreign liquors are almost equal to the alcohol content in distilled spirits. Everclear, that is grain spirit, is one of the highest amount of alcohol content that is available anywhere in the world. This is still found in the US. And South Goa's Feni, which is made from crushing of the cashew nuts, also has quite a significant amount of alcohol, though possibly the Feni that is given to the tourists may be diluted so that they don't get drunk. In addition to this, when we talk about alcohol and we ask our patients what do they drink, we have to be aware of there is something called desi daru. So desi daru is made from molasses, which is a byproduct of sugarcane. And this desi daru includes legal alcohol, which we have discussed, and moonshine alcohols. This is an arak shop and palm toddy. So these also are called in combination desi daru. Now coming to, I started my talk saying that alcohol use disorder is more than 3 drinks per day for males and more than 2 drinks per day for females. So what is one standard drink? Is it 10 grams of alcohol? Is it 14 grams of alcohol? Is it 20 grams of alcohol? Or is it 8 grams of alcohol? So the answer to this lies in the fact that it depends on which country we are in. But majority of the patients feel that the amount of liquid in the glass is equal to the amount of alcohol content, which is not correct. So one standard drink is considered to be 14 grams of alcohol if you are taking US standard. It's 8 grams of alcohol if you are taking a UK standard, and it's 10 grams of alcohol if we are taking WHO standard. So, which is roughly equal to 250 ml of beer or 100 ml of wine or 30 ml of this spirit. So if somebody takes 30 ml of spirits, its alcohol content is almost similar to having a 250 ml of beer. So how do we calculate and how is it done? So let me explain to you. This is a bottle of beer, can of beer, which is 300 ml, and it has 5% of alcohol. And now suppose I need to convert it into grams. So what we do, so we divide 300 ml and multiply it by 5, which comes to 15 grams. On the other hand, if I have a glass of wine of 120 ml, which contains about 12 grams of alcohols, again, we can multiply this, which comes to 14.4 grams. Similarly, a glass of hard drinks, a peg of hard drinks, which is 40% alcohol, one peg is called 30 ml. So you multiply 30 ml into 40 or 43 sometimes, which comes to roughly around 12 grams. So one standard drink is equal to around 300 ml of beer or 100 to 120 ml of wine or 30 ml of hard drinks or Indian-made foreign liquor. But when in clinical practice, we ask the patient, how much do we drink? He hardly tells me in ml. So they use this type of term like a desi pua, sir, I take a quarter. Somebody says, I take a half. Another person will say, I take a full a day. Or somebody says, I take 2 pegs. And there's something called patiala peg. So we should be aware that when we are doing a proper study on alcohol pattern in Indian patients, majority patients will use these words rather than using the words in ml. So what does this mean? So a desi pua is basically 180 ml, or it is called a quarter. This is the one. A adha or a half is basically 375 ml. A khamba or a full is basically 750 ml. A peg is basically 30 ml. And we put 2 fingers, the index and the next finger, that is a 30 ml. And if I fold my middle 2 fingers and I calculate between the index and the little finger, it's approximately 90 ml. It is then called a patiala peg. So based on this, we have to convert it into the percentage and convert it into grams. But this is not required in normal clinical practice. We can just find out the number of drinks the person takes. So I also mentioned that alcohol use disorder means if a patient is having binge drinking episodes. So what does binge drinking means? So the definition of binge drinking has been given by the National Institute of Alcohol Abuse and Alcoholism, and it defines binge drinking as a pattern of alcohol consumption that brings the blood alcohol concentration level to 0.08% or more. What does it clinically mean? Clinically, it is almost equal to a female if she takes more than 4 drinks in a 2-hour period, or if it's a male patient who is taking 5 drinks within a 2-hour period. And the majority of the people who binge drinks are found between the age of 25 to 34, followed by 18 to 24. On the other hand, if somebody is taking 60 grams of pure alcohol on one occasion, it is defined as a heavy episodic drinking. These terminologies are usually important to find out whether the liver disease can be attributed to alcohol or not. In other ways, there are terms called heavy drinking. So heavy drinking is defined as a person taking more than 15 drinks in a week, or a female with more than 8 drinks in a week. Why is this important? Because the concept of heavy drinking is linked to something called a low risk drinking. So low risk drinking means if a female patient takes no more than 7 drinks per week and a male takes no more than 14 per week, or on any single day, if the drinking pattern is less than 4 for males and 3 for females, only 2 out of 100 people who drink within these limits will possibly have an alcohol use disorder. So I'm summarizing what I have discussed till now. Alcohol use disorder is more than 3 drinks per day in males, more than 2 drinks in females per day. Binge, if it's more than 5 drinks in a 2-hour period in males, if it is more than 4 drinks in a 2-hour period in females. Heavy drinker, more than 14 per week, females less than 7. Anything below this is considered a low risk drinking. And anybody taking more than 60 grams of pure alcohol on one occasion is considered to be having a heavy episodic drinking pattern. Now we should all understand that alcohol follows a J curve, because there are some confusion amongst the population that alcohol may be beneficial. So a lower rates, it can lower the risk of coronary artery disease, stroke at mild consumption. But then when it goes above the level, then it has a higher risk of cardiomyopathy, hypertension, atrial fibrillation, hemorrhagic stroke, and cirrhosis. In addition to this, alcohol is a known carcinogen. So we should be aware that there is no threshold level for the existing risk of cancer with alcohol. For example, in females who drink, even a small amount of alcohol has a 2-fold increase in the risk of breast cancers. So this is a very common question, that what is the threshold for development of alcohol liver disease? Our conventional teaching was that up to 30 to 40 grams per day is considered to be safe, but it is not so simple. It depends on multiple factors, including the age, the sex, the obesity. Coffee consumption is found to be protective. Cigarette smoking, presence of bariatric surgery can increase the toxicity of alcohol. Genetics is important. For example, PNPLA3 and TM6SF4, these 2 genes, which are found to increase the prevalence and progression from NAFL to NASH, also causes increased toxicity from alcoholic liver disease to alcoholic steatohepatitis, while this gene, HSD17B13, are found to be protective. We are doing these genetic studies in our patient population who come to the clinic, and we are possibly coming up with a good data very soon. So I also started my talk that it is no longer alcoholic. So the recent guidelines, which was published in the Journal of Hepatology, recommends that we stop using the term alcoholic and use the term that the patient has an alcohol use disorder. Similarly, instead of alcoholic cirrhosis, we can use the term cirrhosis due to alcohol-related liver disease. However, the term alcoholic hepatitis, they feel, is become too standardized, so that we should not change this term at this point of time, but it may be reviewed in future guidelines. So these are the new terminologies which we should be using in day-to-day practice. So we should all understand that patients with alcohol use disorder who develops liver cirrhosis mostly presents to us late, once the symptoms of jaundice and all have started. So it is important to identify the patients at a very early stage. And it is also equally important to know that 1/3 of the patients who present to us usually are in a state of no alcohol use at that point of time. So to try this was a scoring system which is available online. The University of Southampton developed a test to screen their employees who were taking alcohol, and they found that 30% of the patients were having hazardous drinking pattern, which we discussed. And they assess these 3 or 4 markers, and they could divide these patients into green zone, which means there's no fibrosis, a amber zone, which means there is a liver warning, and red zone, which was found to be having fibrosis. So a significant number of patients, up to 40 to 75% of cases who are having underlying liver damage, can be missed if we solely rely on the liver function test. I won't go into the details of this because these are practically not used, but there are some criteria which people should know. This is called the DSM-4 criteria for alcohol use disorder. It identifies few questions. If it fulfills more than 6 criteria, it is a severe alcohol use disorder. If it is 4 to 5, it is moderate. If it is 2 to 3, it's a mild disorder. Similarly, audit questionnaire is what we have started using, but this again is time consuming. We have a coordinator who asks this. It basically takes into account that does the patient drink alcohol, how frequently, how many times a day, do you have more than 5 drinks on one occasion? This will identify the consumption pattern. Then whether the patient was not able to stop drinking once he started, and do the patient often has the eye-opener drink. This will identify dependence. And if the patient has a sense of guilt or forgets what he has done the previous night, or he has been injured or have injured someone, or somebody had to tell him to cut down of alcohol, it is called an alcohol-related problem. This questionnaire is scored from 0 to 4, and based on this, we can identify the people who are problem drinking. But if you have to ask one question in the clinic, if we ask the question, how many times do you every time have more than 6 drinks on one occasion? If the patient says, yes, I sometimes have more than 6 drinks on one occasion, it is almost equal to doing a full audit questionnaire. There are terms which we write in our prescription, but we should be careful. One is called alcohol abuse. So when we say alcohol abuse, the person should be not fulfilling his day-to-day responsibilities. He should be drinking in dangerous conditions like driving. He must have fallen into some legal problems like being arrested, or he has a family issue which has led to because of alcohol use. If somebody abuses alcohol for a long time, he becomes dependent for alcohol. When we say alcohol dependence, there should be a strong craving with an inability to stop. And also the patient spends a lot of time trying to find means by which he can get alcohol, and he gives up other pleasures in life for drinking. So these terms you often see in the practice, in the prescriptions, and each of them has a different meaning. Now coming to the clinical part of it, which many will be interested. So the natural history of alcohol liver disease is that a normal liver can go into alcoholic steatohepatitis. Over a period of time, there will be inflammatory damage, and there will be fibrosis in the early stage, which will lead to disruption of the architecture and loss of liver function, causing cirrhosis. And a small progression of this can go to hepatocellular carcinoma, and to cure, it will ultimately need a liver transplantation. This is a very interesting slide. I have brought this because this is a study which was found to, it's a biopsy-proven study. So in people who drink, 15% people had normal liver histology, and the progression risk was 1%. 27% has just fat, and still the risk of progression was 3%. But if you see, the mortality risk was still 6 to 7%. This is because of mostly non-liver related mortality. On the other hand, people who had steatohepatitis, the risk of progression to cirrhosis was around 10 to 17%, and the risk of death was around 11%. What this slide means, and the message here is that even though somebody may not have steatohepatitis, but just steatosis, the risk of progression is still high, and these patients can still have a non-liver related mortality in these patients at 1 year. So I won't go into the details of the mechanism because it will be a little bit boring. But what we should understand that when does somebody develop an alcoholic liver disease? When a normal person takes alcohol, there is steatosis and lipid droplets, and this will, over a period of time, affect the mitochondria, and some of these will be of these steatotic lipid droplets will be lysed by the autophagosomes, and this is called the lipophagy pathway. However, when somebody's drinking capacity is more than the body's capacity to remove this fat either by the lipolysis pathway or the lipophagy pathway, it is at this point of time that there will be damage to the liver, steatohepatitis, and ultimately cirrhosis. Now, coming to a more important part, which we see in day-to-day clinical practice, alcoholic hepatitis. How do we diagnose? I think everyone is aware of a score which is called the discriminant fraction. So we have been taught that anything below 32 is considered to be a non-severe alcoholic disease, and anything above 32 needs to be aggressively treated, including a trial of steroid, which I will come later. But why I put this here is that we should understand that even patients who have a DF of less than 32, 6% patients have a 28 days mortality, 7% has a 90 days mortality, and 13% has a 1 year mortality. So how do we define alcoholic hepatitis? Suppose a patient comes to our clinic with a history of jaundice, and there is a history of ongoing consumption of at least say 40 grams in females and 60 grams in males for around 6 months, with an abstinence of less than 60 days is allowed. If the AST and ALT ratio is more than 1.5, and the values are usually below 400, and we have a bilirubin of around 3, this fits into what is called a probable alcoholic hepatitis. So this is a clinically, this is called a possible alcoholic hepatitis. That is a clinically diagnosed with some compounding factors. Now, what could be the compounding factors? This patient who is drinking can have a viral hepatitis. It can be taking some drugs, including alternative medicine. There can be some amount of atypical laboratory test, which is not fitting into the classical picture, or the ANA or ASMA may be positive. So these are the potential compounding factors. But if we have removed these compounding factors and it fits into the clinical diagnosis, then we call it as a probable autoimmune alcoholic hepatitis. Now, majority of the time, we only can diagnose in the clinics either possible alcoholic hepatitis or probable alcoholic hepatitis. Because to say definitely that there is alcoholic hepatitis, it has to be biopsy proven. And even in a center with high volume like ours, we hardly do a biopsy to confirm alcoholic hepatitis. We have seen that over the period of time, there is an increasing incidence of alcoholic hepatitis, and the commonest age group at which the alcoholic hepatitis is increasing is between 20 to 29 and 30 to 39 years of age. And we should stop using the term non-severe alcoholic hepatitis, because we should understand that in patients who stop drinking, the 1 year survival is 80%, which means 20% patients still have a risk. And in patients who do not have severe alcoholic hepatitis, also can have a 1 year mortality if there is associated encephalopathy. So it is better to use a term called alcoholic hepatitis of intermediate severity. Now, what are the risk factors for alcoholic hepatitis? We get some patients in the clinic who say, "Doctor, I drink only a little bit of alcohol. Why did I have hepatitis? My friend drinks quite more than me." So it is not always related to the alcohol quantity. It may be related to the duration of alcohol, the pattern and the type and the gender. So there is no clear threshold at which the alcohol damages the liver, but it usually occurs after around 10 years of heavy alcohol use. For alcohol-related fibrosis, if somebody is taking more than 100 grams per day, the relative risk jumps to around 26. Also, how the patient is drinking. So it is seen that people who drink red wine, the relative risk of developing fibrosis is less. But people who are drinking outside the meals, who are taking cocktails, that is mixing more than one drink, there is an increased risk of cirrhosis. Also, the risk of cirrhosis increases in a regular daily drinkers with a hazards ratio of 3.65 versus those who give a holiday and drink maybe 2 to 4 days in a week. Also, female sex is found to be an independent risk factor, and any person who is obese, doesn't fulfill other criteria, is an increased risk. The presentation of alcoholic liver disease is often indistinguishable from NASH. If the patient comes to the clinic and doesn't give us the alcohol history or hides the alcohol history, it becomes almost very difficult to differentiate between non-alcoholic fatty liver, non-alcoholic steatohepatitis, and alcoholic liver disease. So the presence of jaundice is very important, and we should look for other cardinal signs like fever in the absence of infection. If the patient is having neutrophilia, the AST, ALT, as we said, between 1.5, and these values are usually not more than 500. Also, many of these patients can present with a decreased platelet count and picture like cirrhosis. Also, remember that whenever a patient of alcoholic hepatitis, he gives a clear history that he has taken alcohol, yet we should test for the viruses, because hepatitis C, this is old data, of course, that is found to be positive in 16% of alcoholic patients. They may have a coexistent non-alcoholic fatty liver disease, or they may have taken some complementary and alternative medicine. And also keep in mind that Wilson disease can have an AST-ALT ratio of more than 2 and can have hepatic steatosis. So this needs to be always excluded in young patients. There are some biomarkers. This is for academic interest because we don't do it in our real life practice. The conventional test we were taught was the carbohydrate transferrin test, but there are tests like testing the ethyl glucuronide in urine, which can detect 7-day alcohol use, phosphatidylethanol, which can detect 2 weeks alcohol use, and in hair samples, ethyl glucuronide can detect if somebody has taken alcohol within the previous 3 months. Also, there is an important concept coming. In the past, alcoholic cirrhosis were not found to have too much of hepatocellular carcinoma, but this is a study of around 5,000 patients, which found that around 12% of patients develop HCC. It was mostly in males and older age, and majority of the time, the tumor was detected in advanced stage and the survival was poorer than non-alcohol patients. So when a patient of alcohol comes to the clinic, how do we approach this patient? So we should at least try to get an audit score if possible. If it is more than 4 in women or more than 8 in men, plus we have an AST-ALT elevation, we should consider it as alcohol-related liver disease. We should parallelly try to refer to an alcohol addiction specialist who will possibly reduce the craving and try to de-addict this person. And then a hepatologist or a gastroenterologist should be seeing these patients to assess for any advanced fibrosis. If there is no fibrosis, he can be referred back to the primary care. And if there is advanced fibrosis, he should be evaluated in the line of liver cirrhosis. So we should keep in mind that many of the times, these patients can present with ascites, variceal bleed, and encephalopathy, though they don't have liver cirrhosis. So many of these patients are initially sometimes misdiagnosed as cirrhosis of liver, and then they end up with recovery. We should always keep in mind that we ask this patient to suddenly stop alcohol, but we should be aware of alcohol withdrawal. So there is a scoring system for alcohol withdrawal identification. This is a very big score, which takes a lot of time. But again, for academic interest, if the score is less than 10, it means the patient will possibly not go into alcohol withdrawal. Do we do biopsy in alcoholic hepatitis, and why? So practically and honestly speaking, we have hardly done a biopsy in alcoholic hepatitis. It's only when there is an uncertain diagnosis and when sometimes for prognostication and to identify coexisting disease. I will not go into the details, but just a gist of why biopsy may be important, because in patients when the diagnosis is uncertain, 10 to 20% patients who underwent liver biopsy actually did not have alcoholic hepatitis, they had something else. Also, it is to identify the patients who have steatosis versus who have steatohepatitis, that is inflammation. Because if there is steatohepatitis, the risk of progression is far higher. Whether we are doing a biopsy to find out if it is non-alcoholic or alcoholic, to be honest, it is very difficult, but some features like alcohol foamy degeneration and fibro-obliterative changes near the veins and cholestasis are more seen in alcoholic patients than in NAFL patients. Sometimes biopsies are done in clinical settings to identify markers of whether these patients will respond to steroids. If there are neutrophils and low-grade steatosis, it usually predicts that there will be some response to steroids. But these are all theoretical. We are not using it in day-to-day practice outside a clinical trial. So alcoholic hepatitis score has been developed in a study which takes into account whether there is bilirubinostasis, whether there is bilirubin in the ducts, whether there is megamitochondria, as we see in this picture, or whether there is polymorphonuclear infiltration. And then the scoring system is done. If it is between 0 to 3, it is called mild. If it is more than 6 to 9, it is called severe, and 4 to 5, intermediate. But why is it important? It is also important because patients are found to have biopsy-proven alcoholic hepatitis. The mortality is worsened if we have severe disease on biopsy. But again, these are small number of patients in clinical studies. But how do we do it clinically? This is important. Clinically, there is something called the discriminant fraction. So it is also called the MADRS DF. And if it is more than 32, it is considered to be severe. And the 30-day survival in this patient is around 85% in recent trials, which means that there's a 15% risk that this patient will die. However, we should keep in mind that people who have a DF of less than 32 still has a 10% mortality risk. However, this score doesn't tell us about the prognosis of the patient in long term. In addition to the MADRS score, we know about the MEL score that we use in liver cirrhosis. This MEL score cutoff is 15 in cirrhosis, but the MEL score cutoff in alcoholic hepatitis is 20. So a MEL score above 20 means that these patients have a high risk of 90 days mortality. There's another score which is called the Glasgow alcoholic hepatitis score. This identifies the patient at the highest risk of death in absence of treatment. If a Glasgow alcoholic hepatitis score is more than 9, this have a poor prognosis. But if you give steroid to these patients, they will have an 84-day survival benefit. On the other hand, if the DF is less than 32 and the Glasgow score is less than 9, these patients will possibly not benefit with steroids. Coming to a score which we are practically using in our day-to-day practice now is called the Lil Score. This is based on the principle that there is an improvement in the liver function. So when a patient on alcoholic hepatitis is started on steroid, a change of bilirubin at day 7 and the MELD at day 7 predicts mortality. So the score ranges from 0 to 1. And if the Lil score is less than 0.16, they are called complete responders. If it is within 0.16 to 0.56, they are called partial responders. Anything above 0.45 is a non-responder. So this is a scoring system which is you can download in a mobile, and we give steroid to these patients, and then we see the response on day 7. However, again, a practical problem is that majority of this patient will not be willing to stay till 7th day in the hospital. And sometimes it is scary to send these patients on steroids home without knowing whether it will benefit or not. So another study had come which said that if we do the Lil score on day 4, it will possibly be equal as the day 7 Lil score. And if we see these patients are responding, then we can possibly send them off for 28 days steroids. Also, people have tried to use other markers like serum transferrin has been used as a marker to identify the 28 days and the 90 days survival. People do transient elastography, that is fibroscan, during alcoholic liver disease state, though there is a confusion because on one side we say if the liver enzymes are high, don't do a fibroscan, we will get a falsely high value. But what is seen that if these patients stop alcohol, there is a significant decrease in the fibroscan value. We don't know whether it is because of the reduction of the steatohepatitis or the fibrosis itself. People have tried to combine the MEL score and the Lil score, and this has been found to be quite effective, but is quite complicated to use in clinical practice. In clinical practice, we use basically the discriminant fraction, the Glasgow alcoholic hepatitis score, the MEL score, and the Lil score. The Lil score is used to identify response to steroids. So how do we treat these patients? Let us be very clear that there's no drug to treat alcoholic hepatitis actually. So it is mostly nutrition, prevention of alcohol use, and some drugs have been tried, which includes steroids. People have tried pentoxifylline and N-acetylcysteine. So alcohol abstinence is crucial. So we need to give the liver to pick up. So to help the patient in abstinence, many drugs are available like baclofen, acamprostate, topiramate, and naltrexone. We hepatologists favor baclofen, while many of the psychiatrists prefer acamprostate. So this was a study which showed that in patients of alcohol use disorder who were given baclofen at 90 days, 71% patients were able to maintain abstinence when compared to 29% patients who received placebo. So baclofen, we normally use it at a dose of 10 milligram thrice daily, but if the patient feels sedation, we can even reduce it to around twice a day. Studies have used gabapentin in preventing alcohol intake when it was compared with placebo. It was found that 27% of patients did not go back to heavy drinking days when compared to placebo. Also, total abstinence was higher in gabapentin, 18% versus 4%, and it is beneficial in patients who have alcohol withdrawal symptoms. So sometimes we are using this actually for patients who are complaining of a lot of neuropathy, and then we need to give them support for this. Topiramate has been a good drug, but it is limited use because of the paresthesias. There's severe burning in the legs, and many of these people complain of an altered taste. Coming to the most important part, this is something which we all forget. The only way we can treat alcoholic hepatitis is abstinence and nutrition. So how much nutrition? The Aspen guideline recommends that we should calculate to around 35 to 40 kilocalories per kg body weight with a daily protein intake of around 1.2 to 1.5 grams per kg body weight. If the patient is not at all tolerating, even in some sick patients, we can go for tube feeding. The randomized studies have seen that if we do tube feeding versus normal feeding, there may not be a survival benefit, but definitely people whose calorie intake falls below 21 kilocalorie had a very high 6-month and 1-month mortality. So it is very important to identify that nutrition reduces mortality. It prevents encephalopathy and infections. Lesser the calorie, higher is the mortality. Okay. So we have a patient whom we have taken care of his craving. We have asked the psychiatrist to see and give counseling to help him so that he doesn't have a recurrence of alcohol. We have taken care of nutrition. Now coming to the most controversial part of it, that is steroid in alcoholic hepatitis. It is because of divergent results and there are divergent results in meta-analysis. The study says that it can cause a reduction in mortality at 28 days, but nobody knows what happens on day 30 and day 40. So definitely there is some statistical jaggery in this paper. So when steroids have been used, the study compared steroid, N-acetylcysteine, and placebo. When we compare N-acetylcysteine versus placebo in this meta-analysis, we showed that there is not much benefit. When we compared pentoxifylline, which was a drug we have used rampantly before, when it was compared with placebo, again, no benefit. When we have used corticosteroids versus placebo, these are the studies with corticosteroids. It shows that there is an improvement in the short-term mortality. All but it has no effect on the medium-term mortality, that is 3 to 12 months. None of this drug could change the medium-term mortality. Also, this is a study on a meta-analysis which shows that if we compare corticosteroid versus pentoxifylline, pentoxifylline did not work. What we practically use in our hospital is a combination of N-acetylcysteine and prednisolone. So the study shows that if we use N-acetylcysteine and prednisolone versus prednisolone alone, there is a survival benefit in combining the two drugs. But we use the Lil Score and then decide whether to continue till 28 days. Common questions asked: can we give steroids if the patient is having a bleed? So there is a widespread belief that corticosteroid causes duodenal ulcer, but the answer is no. The corticosteroids causes duodenal ulcers only in the presence of concurrent use of non-steroidal inflammatory drugs. So after control of upper GI bleed, we can use steroids. Next question, people are worried about infection. We should understand many of these alcoholic patients, 25% of patients whom we admit are already infected at admission. And another 25, we should expect that they will get infected after the use of steroids. So this is a study which shows that 7 days after diagnosis of infection, after control of infection, the median time to infection is around 14 days. And this is data from one of the famous trial, the STOPA trial, which shows that the commonest infections are either spontaneous bacteremia, respiratory, or urinary tract infections. This study tried to find the basal DNA and see if it is bacterial DNA, if it can predict infection. And it found that yes, the people who receive prednisolone, there is an increase in the risk of infection. So people tried to combine antibiotics with prednisolone. And it was found that antibiotics could actually prevent the infection rate in patients with prednisolone. And this was a study where they gave prednisolone versus placebo and prednisolone with augmentin. A similar study is ongoing at AIG, where we are giving prednisolone plus norfloxacin, and it's found to be beneficial. Many people still keep on asking, why not give Trantel or pentoxifylline? So pentoxifylline has been studied in randomized controlled trial, and it's found that there is very weak evidence to recommend its use in alcoholic hepatitis because there is no difference in the 1 month or the 6 month survival. So prednisolone with or without pentoxifylline, pentoxifylline has no role. There is a role of definitely prednisolone. Quickly, last 3 or 4 slides. There are other therapies like GCSF, that is granulocyte clonal stimulating factor. People have tried anti-TNF agents and liver support systems, and the most controversial, do we transplant these patients? So this is a study from PGI Chandigarh where they gave GCSF to patients with alcoholic hepatitis at 5 microgram per kg for 5 days. And they said that the patients who received it, there was a 78.3% survival compared to 30.4%. However, this data has not been replicable in real-life clinical scenario. Coming to liver transplantations, as we all know, we have been taught that we need a 6 months abstinence before we actually ethically ask a patient for liver transplant. It's not only ethical, it is because when somebody gives up alcohol, within a period of 6 months, many of these patients recover and they don't need a transplant. But over a period of time, the acceptance of early liver transplantation is evolving, and more so in Asia, because in Asian country, it is mostly a living donor liver transplant where the wife or the son or the mother is giving the liver. And this contrasts with the Western data where these are basically cadavers, and cadavers are state organs. So they believe that it should not go to people who don't deserve. But if you see over a period of time, some American centers and Germany and Europe are now listing patients for liver transplant. So there are arguments in favor and there'll be arguments in against. But studies have shown that people who have stopped alcohol for 6 months versus people who have not stopped alcohol, the return to harmful drinking is not very much different. So Mathuran is a person who is a pro liver transplant in severe alcoholic hepatitis. But what we decide is that we should take these patients only if they are strongly motivated to give up alcohol, they have a good social support. We don't promote early liver transplantation for all alcoholic patients who come worsening. So we have to be first convinced. And the words that I used is that in a highly select group of patients who are motivated with a family support and who are worsening without any response to steroid are the ones who can still be considered for early transplantation. People have tried to use S-adenosylmethionine in patients with alcoholic liver disease, but the response has been varied, so there is no possible role. There are newer drugs which are coming up, possibly pan-caspase inhibitors, interleukin agonists like anakinra, and obviously the concept, you may be seeing some bovine colostrum in the market. So this bovine colostrum possibly helps in prevention of the leaky gut, which is thought to be the driving factor in worsening of liver disease, and whether it can prevent and restore the leaky gut and translocation of lipopolysaccharide can be seen in future studies. So these drug targets, I won't go into details. There is also interest on something called fecal microbiota transplant, that it can reduce and improve outcomes in patients and also reduce craving. I think the moment you tell them we'll do FMT to reduce craving, somebody may just give up alcohol. It also definitely improves the inflammatory pattern in patients with alcohol liver disease. So this bovine colostrum, which I was mentioning, so this is a study from only one center in India, and these are pilot studies which shows that it possibly has benefit, including survival benefit. So to summarize, when we have a clinical diagnosis of alcoholic hepatitis, as defined by a recent onset of jaundice or with a history of alcohol consumption, the patient may not be giving a history of alcohol within the last 1 or 2 months. Then we try to do a liver biopsy only if it is a very uncertain diagnosis. We have some abnormal values and we believe that it is not alcohol. And then we perform an extensive screening for infection on the time the patient gets admitted, because our intention is that we may give him steroids. So we need to prime him up to find that there is no infection. We usually send blood and urine cultures. We send procalcitonin. If the patient has ascites, we even send fluid for ascites cultures. And at the same time, we should never forget the evaluation of the nutritional status. Target a protein intake of around 1.2 to 1.5 kilocalories, and with a daily intake of 35 to 40 kilocalories. We should prefer the oral route. Never to forget a vitamin B supplementation in these patients. And then we assess the disease severity. We have defined multiple scores, but we commonly use the MADRS and the Glasgow hepatitis score. If the MADRS is more than 32 and more than 9, these are the patients who will benefit from steroids. If it is less than this, these are the patients who will possibly recover without any specific interventions. We start prednisolone and we combine it with N-acetylcysteine, and then we assess the treatment response on day 7 with the Lil Score. We can also do it on day 4. And if the Lil Score is favorable, then we continue steroid for 28 days. If the Lil Score is not favorable, We are starting to do plasma exchange in some patients to reduce the jaundice and modify the toxins. We are yet to publish the data. And in a select group of patients, we should push them if they are willing and with a family support for liver transplantation. Never to forget the treatment of alcohol dependence by giving support so that the patient can sleep or to reduce the craving, something like baclofen, which works very wonderfully. So finally, the take-home message is that alcohol and alcohol use disorder, alcoholic hepatitis, is rising worldwide. Significant number of patients, remember, when they come, will not complain of recent alcohol intake. We should identify these patients who are at risk of progression. Histology may sometimes identify patients who we think of alternative diagnosis, or it may give additional information about whether they will respond to steroid. Steroid and N-acetylcysteine hold promise in preventing short-term mortality, that is the 28 days mortality, but there is no data on the medium and long-term mortality. Early liver transplantation in a highly select group of motivated patients. Taking care of alcohol dependence is equally important, and diet and abstinence is possibly the only approved treatment of patients of alcohol liver disease. With this, I will end my session, and I'll be happy to take any questions if there are any. Thank you.
Thank you, sir. Extensive and illustrative presentation about the alcoholic liver disease. Almost everything has been covered, sir. Here is my PG teacher and my guide, Dr. Bhagraj Solanki. Sir, any question from your side?
Really, it is very extensive discussion about the alcohol, various types of alcohol, and the various pattern of alcohol consumption, and about the alcoholic hepatitis, and including the recent treatment which are ongoing. But the sir have already touched upon, but I would like to again have a clear-cut answer about how to differentiate in an obese alcoholic about the contribution from alcoholic hepatitis versus the non-alcoholic fatty liver disease.
So this is a very important part because a new terminology is coming up, which is called BASH. That is a combination of both alcoholic and non-alcoholic steatohepatitis. But as I have shown, even a biopsy may not be able to differentiate. The only way I feel in clinical practice is that if the patient stops alcohol and the liver function improves without doing anything, and the patient has not exercised, not lost weight, I will attribute the majority to alcohol. But even after stopping alcohol, if the liver functions are still on the higher side, then we possibly have to think of a component of non-alcoholic steatohepatitis. But we have a definition when we can say it is non-alcoholic. So it basically boils down to whether we are using the Western definition of what is non-alcoholic. But yes, this term called BASH is there, where when we are not sure, we write in our prescriptions also that it could be both alcoholic and non-alcoholic component. But there's no clear-cut answer. Even a biopsy doesn't give that answer.
In that abstinence, is it improving or not? Patient is improving or not after abstinence?
In that circumstances, are we justified in starting obeticholic?
So obeticholic acid, which we are very skeptical with obeticholic acid after 1.5 years of availability in the market. So obeticholic acid, if we think it is NASH, the first thing is that the approved dose is 25 milligram. The dose that is being marketed in India are 5 and 10 milligram. And studies have shown that actually 5 and 10 milligram doesn't work in reversal of fibrosis. So there was a study with 5, 10, and 15. That was the 25. That was the dose finding study. So the other thing is that if we think that there is cirrhosis, never we start obeticholic acid, because now there are 9 cases reported from Mayo Clinic of child-age cirrhosis who after starting obeticholic acid had underwent an acute on chronic liver failure and they needed liver transplant. This is from Patrick Kamat's group. So we are not a very good promoter of OCA, and we should understand that if we are using obeticholic acid for NASH at 25 milligram, the incidence of itching at the end of 3 months is 60% of the patients. And then there's increased incidence of dyslipidemia. The LDL cholesterol rises by around 30% in 50% of patients. And considering that in non-alcoholic fatty liver, the commonest cause of mortality is not liver, it is cardiac. So this increase in lipid profile leads to a more risk. So as of now, that is the precise reason why the US FDA has rejected the obeticholic acid application to be approved for NASH.
Thank you, sir.
But
Over
sir, anything like that with obeticholic acid, if we started with the 5 milligram and gradually improving, and what I have heard that just itching, state is say 60%, but what I have read is around 25%. But what is your clinical practice? Have you started something?
Yeah, so there's actually a question here that there's a study which says that patient-reported outcome, that is, we don't tell the patient that you will have itching. And there is something called investigator-initiated itching. So this is a paper which was published in ASLD that the investigator keeps on asking the patient that I started obeticholic acid, are you having itching? So, and it was very surprising that the risk factor of itching were found to be female patients, patients who had psychiatric comorbidities, and there was the third one I forgot. So, but they said that the patient-reported outcome, if you don't tell them that you will have this side effect, is actually much less, as you said, 25 to 30%, when compared to what was documented in the original trial.
Bhavin bhai, any question from your side? Nilesh, are you there?
No. Already sir described all the etiology and the related treatment and the pathological findings from my side.
Nilesh, are you there?
Yes, I'm there.
So, Dr. Nilesh Godani, sir, he is gastroenterologist in our team right now. Any query from your side?
No, present.
Sir, few doubts from myself. Okay.
Yes.
First of all, regarding the infection, we start a steroid. Usually what happens in the private practice, not an institutional practice, when we go to see the references or something like that, already patient is something like monosef or cefoperazone salbutamol is going on, ceftriaxone, something like that. Okay. Now, suppose we go for the traditional institutionalized practice, we usually don't start any antibiotic in alcoholic hepatitis. And we plan to give a steroid. Okay. And in your slide, you have stated that the infection should be recovered at least for 7 days, or it should be out of patient. So there are few subtle infections that we can't able to rule out the patient is an infection or not, something like that. So is there any specific criteria to rule out that is there any ongoing infection before starting steroid?
So first of all, we don't take WBC count, we cannot take because it's already increased in patients with alcoholic hepatitis. So what we do is that we practically cultures of everything, blood culture, urine culture. If those are negative, we start the N-acetylcysteine first. We practically tell the patients that the first 2 days you will be receiving N-acetylcysteine. And then if your cultures and all procal and all comes normal, then only we start. But yes, we also have lost patients after starting steroid. And it's very difficult actually. Being in an institute, it's easy to say that we are using it. But I'll agree that in clinical practice, because we have also seen very good response actually when we have used plasma exchange. Dr. Anand Kulkarni and me are just publishing a study on that. So that is found to be far safer as regards to infection and can give a good control as well as a bridge to recovery in these patients.
Sir, regarding the plasmapheresis, I have recently, from CMC Vellore, I have attended a lecture regarding the plasmapheresis. But is there any specific objective criteria before starting a plasmapheresis in alcoholic hepatitis?
If the patients, the 3 criteria we use, if the INR is high, if these patients are having mild NCAF-like picture, if there is intractable itching, and if there is a concomitant drug-induced liver injury like CAM intake, those patients respond well. Other than
drug injury like alternative medicine.
alternative medicines. So it helps in reducing the cholestasis. So with these 4 things only we initiate. But our protocol here is that we first try for steroids, but if you are not convinced that you feel that there is some infection.
Bhavin bhai, your mic disturbance is going on, I think. Please mute yourself, Bhavin bhai. Thank you.
So if this 4 criteria are fulfilled, then we start plasma exchange. Now there are only 2 studies on plasma exchange. One is from the West, which is with a double volume plasma exchange, and the latest one is from ILBS, which is a single volume plasma exchange from Rakhi. So both these say that both are equal. So in our center, again, we use single volume or the standard volume plasma exchange if the patient doesn't have acute liver failure. But in patients with ALF, we still go with a double volume plasma exchange, but you need to have a very supportive blood bank to give you the volume of plasma. That is another crucial point there.
So, sir, you say that the mild hepatic encephalopathy, you are considering of plasmapheresis. Okay, but with patient with hepatic encephalopathy and cultures are negative, still you are giving the trial of steroid before starting plasmapheresis?
We are still giving trial of steroids in grade 1 encephalopathy. But if the patient is in grade 2, grade 3, we definitely don't try to, because the concept here is that if somebody has encephalopathy, we need to first find out any occult infection we are missing.
And what time you will wait after starting the plasmapheresis? 72 hours?
The plasmapheresis, we do a daily session. At least we do 3 sessions. So, but it's a costly. So at our center, it costs around 60 to 70,000. So at least 3 sessions is what we wait before we tell the patients that it's not responding. But majority patient, it comes down, but then it will pick up slowly over the next 7 to 10 days. So recently we had patients of Giloy-induced liver injuries and all, whom we did some 8 to 10 plasma actions, but ultimately went into transplant. So those type of, but definitely in 2 to 3 sessions, majority of the patients reach a respectable level of around, say, bilirubin from 30 comes down to around 10, 9, and then we discharge them and follow them up. And 25% patients will come back with a higher bilirubin again after 10 days. So that also happens.
But means this is, I think, because everybody said this is really promising.
But there are no studies on alcoholic hepatitis. The only problem of doing this study was that we need to do all the markers, inflammatory markers before and inflammatory markers after. And that is a huge cost. So if even in clinical study, it takes around 25,000 per patient. And the patient doesn't pay this. So to establish a very good study on this needs funds.
Second, sir, on one slide you have said it's a probable AIH versus possible AIH, and few are typical lab tests. Now, suppose patient is taking alcohol, and there are few atypical lab tests because we are planning to give steroid in some cases. So, how much you impact this atypical lab test because before starting the steroid or giving your clinical diagnosis of autoimmune hepatitis? Because HCV Wilson's already you have said there may be some coexisting disorder also.
Right. So those HCV Wilson's automatically we rule out. That's a different thing. But if we are talking about the ANA positivity, so if somebody comes with an ANA positive, we usually see the IgG levels. So if the IgG levels are also high, and then we sometimes maybe not all patients, I will say, if our clinical suspicion is high and the patient is keeping on denying that he has taken significant alcohol, it happens many a time. So we had few patients whom we admitted that alcoholic hepatitis turned out to be autoimmune hepatitis. But we need a high globulin at least to do biopsy. Biopsy sitting in an institute is very easy. People accept it. But the thing is that sometimes if you're giving steroid, if it is autoimmune or alcohol, the outcome is same. So it becomes very difficult to differentiate. Only thing is that whether we need to put these patients on long-term immunomodulatory therapy is the question. But definitely with only ANA positive, to be honest, we neglect. But with suppose ANA, asthma, both are positive with IgG high, then we definitely try to get a biopsy before this.
So means basic point of discussion for the audience, even patient is taking the alcohol, And few or typical lab tests is there. As her slide says, it is around 15 to 25%.
Yeah.
Having alternative diagnosis also.
Yeah.
So don't keep in mind that it is alcohol. So first thing. Second, sir, you have seen that the progression of the liver disease. Is there any marker that this patient comes with the alcoholic hepatitis? Apart from the abstinence, any objective clinical, biochemical marker that this is going to develop cirrhosis in future or something like that?
So biochemical markers are very difficult to say, but a low platelet count is something which we always take as a marker of possible portal hypertension. As we discussed, fibroscan values are bound to be high during the acute stage. But if these values come down after abstinence, that is a promising marker. And finally, we do endoscopy in these patients to also see even very carefully for varices. And if there is a splenomegaly, again, we are working in a part of the country where we have a lot of patients from Eastern zone. And many of these patients have hemoglobin E disease and hemoglobin E trait. So splenomegaly can be sometimes very deceptive in this patient. But what we see is the platelet count. But all said and done, in acute alcoholic hepatitis, the platelets may be low, there may be ascites. It can be actually indistinguishable from a cirrhosis. So if these patients recover after an abstinence, then these are the patients we think have a good prognosis. But the ones who persist after even around 3 months is what we think, 90 days, are the ones who will possibly progress further. We are not doing those fibrosis markers in our hospital, the non-invasive fibrosis blood-borne tests.
Regarding, sir, the 1 year mortality after alcoholic hepatitis, you say whatever the data, it is patient is abstinent from the alcohol despite of this mortality. So is there any specific criteria that this patient has a high mortality? Let's rather than waiting, let's evaluate for transplantation or something like that.
No, for transplantation, there is no data. You're asking for transplantation, right?
Yes.
Yeah. So
because if suppose there is some marker, I'm thinking that this patient though have recovered from the alcoholic hepatitis, but possibility of mortality is high at the end of 1 year. Let's evaluate for transplant. So patient means.
I think the only marker that we found out in clinical studies was the presence of encephalopathy. So it is around 28% in patients with alcoholic hepatitis who can have a recurrent episode, and this can go into, despite the absence of overt cirrhosis.
Overt cirrhosis?
Yeah. So that was a study on 5,000 patients. So encephalopathy was the only marker which is said to have an increased 1 year risk of death. But other than that, and that I have shown that slide, actually I can share you later. So that slide actually mentions without cirrhosis. So that was a very strange study, and but statistics can be sometimes very deceptive. In clinical practice, I don't know whether how much it boils down to non-cirrhotic patients having risk of mortality. But these are not for transplantation. So it's a mortality marker.
Regarding this audit questionnaire or alcoholic use for the practice, not in institutional practice, do you really think there is some question, clinical question from the audit questionnaire or amount of the alcohol, that single 1 or 2 questions will help us to differentiate that this is alcoholic liver disease or not?
So that audit questionnaire, it mentions in that if you ask only one question, that how many times you take more than 6 drinks, possibly it is almost equal to getting an answer that he has a problem drinking. And maybe we can ask how many drinks you take and how do you binge drink. These are the questions I think which can at least be asked.
Anything else anybody wants to ask? So there are few resident doctors here also, from the Gujarat, across the Gujarat. Any specific message you want to give to the resident doctors? So
the first message is that suspect alcoholic hepatitis, even if there is no recent alcohol use. This is what I find in my resident who telling, sir, he has not taken alcohol for 30 days. So this cannot be alcoholic hepatitis. Second, don't suspect alcoholic hepatitis if your liver enzymes are more than 500. It is hardly correct. In that case, with atypical markers, think of alternative diagnosis. Try to always search for infections in these patients. I think everyone should go to the latest New England Journal paper, which has come, How to Manage Infections in Patients with Liver Disease. It was just published in June. And finally, it depends on the center where you're working, whether you were allowed to use steroid or not. AIG was also very conservative in using steroid till a year back. And then we started using and we got some good results. So we are using it more frequently. And there will be more of clinical parameters which you need to look at. Try to do a scoring system always and try to see whether the scoring system actually is predicting that. You can just make a phone call to the patient and find out from the family whether he is alive, to just know that whether this MEL score or this GAA score, because there's no validation of this score in Indian population. These are all Western data.
I just want to say, sir, in
Never
our
forget
residence,
nutrition. Never forget the nutrition part and the support system part, that you need to support the patient so that he gives up alcohol.
in our residency, sir, Bhagirath sir, we used to do a plasmapheresis for GBS patient.
Yeah.
Yes.
So I think because this is a costly in the private sector, but plasmapheresis is relatively
Actually, it's the
free
same.
of cost in
It's the
civil.
same plasmapheresis. It's the
Same plasmapheresis. So it's a free of cost in the civil.
Same.
So I think we should try in the civil patient because there is a high mortality in alcoholic hepatitis, and this is the relatively free of cost in the civil hospital, and most of the patients are poor in the government hospital. So this may be tried.
Free of cost in the government settings, particularly tertiary care hospitals and medical colleges. We do use not only for the GBS, but sometime in a non-responding ITP patients and so on and so forth. We use it as and when required.
So our hospital also, we have a neurology department, so we are using it in GBS and ITPs. Also the same plasmapheresis.
Even too, we have autoimmune hemolytic anemias also.
Yeah, correct. Even in that.
So it's the same, means our pathology department was also very supportive at that time, sir. So I think in few, I will definitely call you personally or to learn about the plasmapheresis.
Sure.
I will definitely try in few patients. But
only point, the patient should be fit in a cardiovascular fitness should be there, should sustain the extracorporeal blood which comes out. And if the patient can sustain, it is really good for the young and middle-aged patient, if it is indicated.
And sir, second thing about the fecal microbiota transplant. How much is it clinically?
We did it only 2 patients. So, and it was a very messy affair. The acceptance is extremely low.
Okay.
So we did it not in alcoholic patients. We did it in patients with chronic hepatic encephalopathy. But we did not get any result from that. So it was done through a nasojejunal tube. And you have to prepare it with a mixie and all those things. So, and to find a healthy donor is again a mess because you hardly find anybody who has not taken this medications, this antibiotic within the last 1 month. But I think ILBS is using quite a lot of FMT. They do multiple sessions, 3-4 sessions. We tried in 2-3 patients, that's it. Other than that, as of now, it is in the freezer.
But I think plasmapheresis is coming.
Plasmapheresis is something which is promising actually, and it helps, which gives instant results. Sometimes even patient accept it as a bridge. Somebody who is the bilirubin of 40 is itching like hell. So you do plasmapheresis within 1 day or 2 days, his itching and all goes off, even if it's a temporary, but people accept it.
Then it can be useful in any cholestasis with itching?
Yeah, we are using it. We are using it cholestasis. We are using it
without alcohol also.
No, without alcohol. So we are using, our most common indication has been drug-induced liver injury, induced cholestasis. So particularly in this COVID time, we had so many drug-induced liver injury, which have been continuing for 3 months, 6 months now, and all are cholestatic pattern. So this is where we have been using it the maximum. And second is in alcoholic hepatitis. Third, even in acute and chronic liver failure. In acute liver failure, but acute liver failure, the results, we are still not sure because though the studies have been on acute liver failure, we feel the surges that happen during the circulation, sometimes it doesn't, the patient don't tolerate it.
Cytokine, maybe more disrupting.
No, as sir said, that cardiovascular instability is more in these patients and they don't tolerate it rather than the other patients.
But I think in CMC they are using in ALF only.
No, all our studies are in ALF only.
Uh-huh.
There's only 2 to 3 studies, big studies. So they are all in ALF.
Any such specific paper you recommend to read
So
before starting plasmapheresis?
I can share you a presentation. I recently made a presentation on plasma exchange,
Okay.
plasmapheresis for this one. I can share it with you.
Please share me. Sir.
Sure.
If there is a doubt, I will come.
Sure.
Anybody wants to ask anything? So thank you, sir. Thank you very much. And it is our privilege and honor, and definitely the type of the alcohol and the amount of the alcohol. That is the usual question during the residency days.
Yeah.
We don't know the exact
Yeah.
answer till date, to be very frank.
Yeah,
It is
exactly.
very
Nobody knows.
extensively,
Yeah.
I think must be, this is very delightful, I must say. And thank you. And we will keep harassing you.
Sure. Sure.
And I will ask you
Very nice.
we will this is our planning to keep this type of lecture at least once in a month, exclusively on hepatology. Okay, so I will call you again for some interesting topic, and usually take opinion from the resident doctors. What you want to learn. Okay, so if you're in your convenient time, usually sir, we will reschedule your lecture.
Sure. Sure. Thank you.
Okay, thank you very much. Thank you very much.
It was a pleasure to meet
And
everyone.
I thank Dr. Solanki sir, Dr. Bhavin Modi sir, Dr. Parthiv Patel, Dr. Nilesh Godani, and everybody who has actively participated in this discussion.
There
Yes.
must be the residents. Sorry to interrupt. Residents who have joined is probably from the civil hospital, because today morning I sent the link to them and told them to attend. That it would be a very fascinating. If you attend it, it would be very
Actually,
informative.
sir, I have asked this pharma company to take the data of all the resident doctor of entire Gujarat and please forward this to them. So I don't know they have forwarded it or not, but definitely our Surat civil and swimmer I have forwarded.
I think one of sir's student came and showed me your message.
Yeah.
Hardik. Hardik is
Hardik
there. So Hardik was very happy. He came and said, "Sir, send me this." So he came to me and showed me your message today. Yeah.
Yes. Yes, sir. So nice of you.
Yeah.
Thank you for remembering.
Yeah. No, he says he's my teacher. He's one of the best teachers there. So I said it will be a pleasure to meet you.
Oh,
Thank
sir.
you so much.
Sir, thank you.
Sure.
Thank you, sir. Thank you very much.